said, today is the second part of a two-part series on respiratory compromise. I'm very excited today because this is the first time we've done a panel discussion as part of a webinar, and I'm really fortunate to be supported by such a strong panel of presenters today. My name's Carolyn McCoy. I'm the Director of Professional Practice for the Canadian Society of Respiratory Therapists. I'm very happy, like I said, to be here with my panelists. And Tom, I just got kicked out of the... There we go, I'm back. Sorry, my screen just went dark there for a sec. So I apologize, but I'm happy to welcome our panelists today. First, we have Cheryl St-Croix from Newfoundland. Cheryl's the clinical leader in respiratory therapy at the Eastern Health site, or in Eastern Health at the Health Sciences site in St. John's, Newfoundland. And Cheryl has an extensive background in intensive care, general therapeutics, hyperbaric sleep, pediatrics, PFT, bronch, anesthesia, and is presenting some of her experience with remote monitoring today. Marco Zaccagnini is a respiratory therapist in the Department of Anesthesia and Critical Care at the McGill University Health Centre in Montreal, and he's the reigning respiratory therapy Olympics champion from our conference. And Andrea Winnick is a professional practice leader for respiratory therapy in Vancouver at the Vancouver General Hospital, where she got her start as a bedside RT for a number of years before she moved into her current position. Now, if you missed our first webinar on October 11th that looked at the risk factors for respiratory compromise, you can always go back later and watch that. It's available on the CSRT website under the Resources tab. You don't need to have seen that to make sense out of what we're about to talk to today. In terms of disclosures, there's really no conflicts to disclose. No one in the panel is an employer or employee rather of any of the monitoring companies that we'll discuss. Some of the monitors may be mentioned, some of the companies may be mentioned, but these aren't taken to be endorsements, and there's been no financial gain or personal kickback from those. What we're going to do today is we're going to take a quick look at some of the risk factors that were presented by Dr. Michael Mestek on October 11th. We'll look at the non-invasive monitoring options before we turn things over to our panelists to describe how they're using remote and or continuous monitoring in their sites. Finally, to end things, we'll look at some strategies that you can use to get monitoring implemented at your site or just to implement change in general if there are other processes that you feel warrant a change. So what does we mean when we talk about respiratory compromise? Respiratory compromise is a deterioration in respiratory status that has the potential to progress into failure or death, where early interventions or timely interventions, enhanced monitoring may prevent that decompensation, that deterioration. The key with respiratory compromise is really preventing that respiratory insufficiency through early detection. Respiratory compromise is a leading cause of intensive care unit admissions, of rescue calls, code blue calls. It's costly for our healthcare system. It's often preventable, and some of the data out there suggests it's preventable in up to 2/3 of the cases, and we know that respiratory failure can be deadly. Dr. Mestek did a great job of giving some of the statistics to back that stuff up in the first webinar, so I encourage you, if you're looking for those types of statistics, to go back and watch that webinar from the 11th. Respiratory compromise occurs across the continuum of care. And this was one of the images that Michael used in his presentation, courtesy of Medtronic. And if you look at the boxes on the right-hand side, we have the progression of a patient from the operating room to a post-anesthetic care unit to a general care floor and discharge. And respiratory deterioration compromise can occur across any of that point in care. The same thing happens for the patient coming in, having a procedure. Respiratory compromise can occur during the procedure, during the recovery process, through to discharge and into the community. The same thing with our medical admits and emergency room admissions. These folks can end up going from emerge to ICU to a general care floor, or going from a medical admit to a general care floor and through to discharge, and are at risk of respiratory compromise at any point along that care timeline. And the risk factors for respiratory compromise are quite extensive. This is a handout from a recently launched CSRT respiratory compromise toolkit. And it groups the respiratory compromise risk factors into 4 different categories. We're going to focus a lot today on the patient and procedural factors, but also there are some caregiver and institutional factors that we need to take into consideration as RTs to help protect our patients. I invite you to go to the site and download that and download references if you'd like to dig into those a little more deeply. But generally speaking, when we're talking about the patient-related and procedural-related risk factors, they relate to either a control of breathing issue, respiratory or thoracic mechanic, to airway integrity, parenchymal disease, or cardiac and perfusion problems. So those types of risk factors can actually lead to 3 physiologic pathways that may take the patient down the chain for respiratory compromise. And we're just going to spend a quick minute to revisit those before I turn things over to the panelists to talk about monitoring. The first pathway, or type 1 respiratory failure, is really due to hypoxemic respiratory failure. In this case, what we have is an issue with oxygenation. Pardon me. So, for example, pneumonia, congestive heart failure. With type 1 respiratory failure, the impaired diffusion of oxygen into the blood results in a decrease in saturation that's accompanied by an increase in respiratory rate. So if we look at this graph that's been adapted from a really good paper that was published in 2011 that looks at the root cause analysis of unexpected hospital deaths, when they focused on respiratory failure, they noted that they combined all the vitals and stats from the cases that they reviewed, and they saw that with hypoxemic respiratory failure, what we see initially is that elevation in respiratory rate and minute volume, and that continues to elevate before we start to see a decrease in saturation. Of course, oxygen saturation decreases may be masked a bit by oxygen therapy. And then we start to see that deterioration in CO2, followed by that spike in exhaled carbon dioxide levels as the patient starts to deteriorate. So with hypoxemic respiratory failure, the deterioration in respiratory rate and the increase in respiratory rate and minute volume is an early sign of this type of respiratory failure. If you look closely at this particular graph, you'll see the respiratory rate hits about 30 before we start to see that drop in SATs. Sorry, I'm just getting an error message here. Tom, is this for me needing to call in? Oh, not surprised. Okay, sorry, folks. That was a message about one of our...
Sorry, someone's just saying they can't hear. Someone's just saying they can't hear, and I'm telling them to call in. So.
Okay, no, my phone started buzzing at the same time, so I didn't know if you were trying to text me at the same time. Okay,
no.
So we're good? All right, yeah, so what I was saying was what we start to see with hypoxemic respiratory failure as the early sign is that increase in respiratory rate and minute volume, followed by that drop in saturation as a late sign. So if you were to monitor saturation alone, you may not notice the deterioration until later stages. And also, if you're monitoring just CO2, you also won't notice the deterioration until later stages because as the respiratory rate climbs, we see that decrease in exhaled CO2. The second type of respiratory failure is hypercapnic respiratory failure or ventilatory failure. In this case, we have inadequate ventilation secondary to an impaired drive to breathe. So perhaps opioid opioid use or sedation, brain injury, or other causes of hypoventilation, perhaps hypoventilation syndrome, obesity hypoventilation syndrome. In this case, what we see happening early is that increase in CO2. So if you remember from our previous type, the rise in CO2 occurred quite late. With hypercapnic respiratory failure, the elevation in CO2 occurs quite early before we start to see that change in saturation. And again, we see that the oxygen therapy blunts that drop in saturation, so it makes that an even later occurring sign. Respiratory rate can remain fairly constant. It can increase or decrease. So it's not as sensitive a predictor of respiratory failure with hypercapnic respiratory failure. In this case, if you monitored only saturation or saturation respiratory rate, you wouldn't detect the failure until the late stages. The third physiologic pathway that was presented on October 11th was arousal failure. So this would be typical of someone with sleep apnea, for example. So what you see are recurrent apneas and hypopneas followed by these periods of normal breathing associated with an arousal. This is all well and good as long as the arousals occur, but if the arousals are blunted, for example, due to post-op sedation or post-op pain management, then we start to see that deterioration in saturation, the climb in CO2 as the respiratory rate and minute volume decrease as well. So if we look at those three different pathways, in one we see a change in respiratory rate as an early sign. In the second one we see a change in CO2 as the early sign, and with arousal failure we see them all changing and fluctuating. So monitoring one or two channels or parameters only alone may not be sufficient depending on what type of respiratory compromise you're worried about. In terms of monitoring, your options really focus on, do we use standard nursing and respiratory care? So your Q whatever spot checks by respiratory with interim spot checks by nursing? Do we look at using continuous monitoring of pulse oximetry? Or do we look at using continuous monitoring of ventilation? Or do we look at doing a combination of things whereby the patient has monitoring for, continuously for a period of time of their oxygenation, their exhaled CO2, their respiratory rate. So you really get a whole picture of what's happening from an oxygenation and a ventilation perspective. What we can do as well, and what we're going to hear from one of our panelists, is monitoring doesn't always have to be done with the patient in the room. You do have remote monitoring options, and we'll see how that's been implemented in Newfoundland here in just a minute. But some other important considerations to consider are, how do you set your alarms appropriately so that you don't have alarm fatigue, but they're set sensitively enough that you do pick up on the early stages of respiratory compromise? So, without further ado, I will turn things over to Cheryl, who will talk to us about what they're doing in Newfoundland.
Thanks, Caroline. So here, as Caroline said, here at Eastern Health, as well as many other centres across the country, this idea of respiratory compromise, especially in the post-operative period, is of obvious concern. Just to give you a little history on how we dealt with this in the past, prior to what I'm going to speak about, is we had a policy in place where we did follow CSA and ASA guidelines and had some policies in place around monitoring these patients post-op, as well as the length of stay in our recovery rooms, the kind of special care units that they would go to, and we have policies around all that. The monitoring piece of that was continuous pulse oximetry with either a 1-to-1 or a 1-to-2 ratio of either nurse or RT for each patient. Obviously, this became problematic for a number of reasons. There were, again, we were looking at getting to the patient earlier to prevent any adverse events. As well, from the staffing issue, it was resource intensive. There was a lot of slowdown in turnover from the recovery room and the like. So to help alleviate some of that, we have currently started a pilot project. And again, we are still in the pilot stages and trying to iron out, I should say, all of the issues that come along with this. So basically what we had in this past year, there were some machines bought from Medtronic about 5 years ago. And I think this was initiated by the anesthesia group, who were trying to come up with something better than what we currently had and take much better care of our patients. So as an addition to this monitor, it didn't just monitor saturation and continuous pulse oximetry, and it had the addition of the end-tidal CO2 monitor. So our pilot project we started off with the surgery program, and it's in conjunction, the team consists of nurse educators, nurse managers, respiratory leads, professional practice from both nursing and respiratory therapy. We have anesthesias involved. The surgery program chiefs are involved. So it was a huge group of people who came together for this one reason. So the pilot project rolled out. Currently, we have put through 117 patients through this pilot project. And it consists of, when a patient comes from the OR and is suspected sleep apnea or diagnosed sleep apnea but are non-compliant with therapy, they now go, instead of having to go to a special care unit, which is not always available, they now can go to just a regular ward, and they go on the continuous monitor. From there, that monitor, each nurse, there are 2 nurses in the system who carry a cell phone. So every time there's an alarm generated by the patient, it has X number of seconds to get to the first nurse. If the first nurse is busy and cannot respond to that, it goes to the secondary nurse. So the primary nurse responds or not. If the nurse, and in order to respond, I should add that the nurse actually has to go into the room, look at the patient, do a full respiratory assessment, which we did a lot of training with every nurse. So there was a lot of work put into it prior to that, where we did a lot of training with nursing to fully understand what end tidal was and how to properly assist from a respiratory point of view. So the nurse goes in, does her assessment, and resets the alarm, which then negates it going on to the secondary nurse. If the first nurse, primary nurse, does not respond, it actually goes to the secondary nurse, which if the secondary nurse doesn't respond, the alarm goes back to the primary nurse. And there's no other way to actually turn off the alarm other than to go in and see the patient. So this alleviated the 1-to-1 or the 1-to-2 ratio. The respiratory therapist sees this patient. They know their role is they are notified when the patient comes the day of surgery. They then see them when they go up to the ward. They usually do a pre-check in the pre-admission. Then they see them when they go to the ward, and they see them every 4 hours while they're on continuous monitoring. That's both day and night shifts. Every 4 hours they see them. Also, if there's any type of respiratory compromise noted by the nurse, there is a call to either the RT or MD who's on call for that particular patient, that particular ward. So now the patients can receive continuous monitoring of not only SpO2, respiratory rate, heart rate, but they also have the end tidal piece of it. And so far, I'm happy to say that we've had, as I said, 117 patients go through this pilot project, and only 2 have gone to ICU because of poor respiratory compromise, because they were compromised, from a respiratory point of view. So we had 2 ICU admissions, but the biggest, I guess, overall take home from this was that we seem to get there earlier to avoid admissions such as this. Now, again, some patients automatically go to special care units or to the ICU postoperatively because of our policies around who goes where, depending on their comorbidities. So right now we're hoping that this pilot project will be scheduled to roll out into our sister hospital at St. Clair's once we get all the issues rolled out here. Caroline or Tom, I'm having trouble forwarding my slide. Okay. So along the way, we have had some, I guess, issues with the whole, or challenges, I should say, with the whole project. One of which was who takes responsibility from a physician point of view. Should it be surgery? Should it be anesthesia? Surgery, I guess, said, well, that's not really their area of expertise in regards to sleep apnea. So in our pilot project, we actually had one of our anesthetists who became the champion of the pilot, who we are very happy to have on board. And he takes sole responsibility right now for all the calls during the pilot. And we're in the process now of rolling this out further into the acute pain services. And it looks like that is going to be who this project is going to fall under. So identifying patients with OSA, because unfortunately, I'm sure like many sites, especially with emergency surgeries, or if it didn't happen in the proper way in the pre-admission clinic for identification of patients who are suspected or non-compliant with treatment who have OSA. Those are some of the biggest challenges we have, is identifying those patients prior to them coming in so we can prepare in advance for these patients and make sure that we have everything in place as to avoid any upset during the day or any cancellation of surgeries. There's also challenges, I guess, when they're in hospital as treatment and the follow-up after that. So we've developed a lot of guidelines around that, or are developing, I should say. Again, they're working documents around having good pre-admission identification. We have order sets that we have done up for these patients. And again, we have follow-up. We're doing some follow-up pamphlets of what the patient should do on their end if we see that we deem them as being suspected of having sleep apnea. And those who we have treated, I guess in this particular hospital, we usually have a respirologist involved. So we usually consult them to see what treatment they would need while they are in house here at Eastern Health. And I think that's about the gist of it. If anyone has any questions, or if I left something out, I'd be happy to.
We just have one quick question, Cheryl, from Greg Spratt, who asks, of the 117 patients transferred to ICU, you had 2. Was that an improvement from before monitoring?
Absolutely. In the past, we didn't have exact numbers, but we do have, a lot of these were put in our intensive care units prophylactically, because we didn't have this monitoring, so or in the special care unit, but mostly we don't have a lot of room in our special care units, and we don't have a lot of special care units. So a lot of these patients just did an overnight stay in the intensive care unit. And I should add, from a monitoring point of view, there's also challenges of when to stop the monitoring. So we're trying to develop better guidelines around what constitutes a patient who's stable enough to come off the remote monitoring.
Great, thank you. All right, so Marco, I'll let you talk about your experiences.
Thanks, Cheryl. Thank you, Carolyn. So just to reiterate, my name is Marco Zaccanini. I work in anesthesia and critical care at the MUHC. So my portion of the respiratory compromise is really discussing the history of end-tidal CO2, first in the OR, because we've had it for so long, in the ICU after that, and then just follow up with some ACLS type of guidelines and end-tidal CO2. So in preparation for this webinar, I began by discussing with a lot of senior anesthetists and RTs about how end-tidal CO2 got started in Montreal. And the recurrent story I kept getting was that the reason it became available was that there was a case at a particular hospital that they placed a patient prone. There wasn't a recognized tube misplacement, and actually resulted in the death of a patient. Now, this is all anecdotal evidence, and I wasn't able to find anything else, but I think it highlights the safety concern of constantly monitoring end-tidal tracheal tube patency breath by breath. So the Royal Victoria Hospital was actually the first to get end-tidal CO2 monitoring in the 80s on their Boyles type of anesthesia machines. And they were apparently the first ones across Canada to own it, and it was extremely expensive at the time, over $1 million. And the RTs had no idea how they secured funding for it. And then on top of that, it actually wasn't great, because if a patient had pulmonary edema or any type of secretions, it would block and shut the entire machine down. Between 1985 and 1990s, they actually changed monitors to allow easier implementation on all patients. And then the RTs just kind of followed suit of the anesthetists and just put it on every single patient before even implementing any type of formal protocol. It was just the norm that as soon as a patient came in and got any type of sedation, they just put it on the patient. And between 2000 and 2005, the Ordre Professionnel d'Inhalo du Québec, our professional order, began conducting professional audits. And they were actually quite interested in the usage of end-tidal CO2, and they put a position paper out that's in the references. And what they did is that RTs in the OR actually stay by the patient's side and monitor all the vital signs, every Q5 minutes. And they made it legally mandatory that on all charting of the anesthesia records that we chart the level of consciousness, the respiratory rate, the saturation, NIBP, and EKG. And at that point, it led to a formalized protocol to actually help us and help the RTs facilitate our charting. So then it just followed suit that everybody guaranteed to get it on as soon as they walked into the OR. I'm just going to ask to go to the next slide because mine apparently is not working. Great. So regarding end-tidal CO2 in the ICU, in 2000, the American Heart Association guidelines, they put a small note of a strong suggestion for end-tidal CO2 usage to confirm the tube placement. And because it was a level 1 trauma center, all the RTs took it upon themselves to fight for it, to have it in the emergency room for intubations rather than using a qualitative calometric, which seemed very simple because the OR has historically had it for so long, but it was actually downright refused by management on the basis of cost. In 2002, the Montreal General Hospital, the trauma center, opened its new ICU, and with that came new monitors, which had the optional module to include a mainstream end-tidal CO2. At that point, the ICU attendings began pushing for end-tidal CO2, not only for confirming intubation, but they also use it, interestingly, for trending ICPs in head traumas. So originally, they targeted a very low PCO2 to induce the patient in a state of hypocarbia, and this allowed them to maintain that state and make the neurosurgeons very happy. And it also helped the RTs with their weaning protocols by correlating the end-tidal CO2 to the PCO2 and then titrating the pressure support levels accordingly. At this point, you save the patient's blood and decrease the possibility of cross-contamination by opening and closing the arterial line. Finally, because the attendings jumped on it, the RT department decided to purchase about 8 modules for 25 beds, which made its widespread use totally impractical. And the reality was that they used it for the prior mentioned reasons, but actually had no idea it was very good for cardiac arrest type of situation. The main barrier for them during the cardiac arrest was that if one of the 8 mainstream modules were not in the room, they had to go find the unit, heat it up, calibrate, which took anywhere between 10 to 15 minutes, which is impractical in a cardiac arrest situation. Another disadvantage of post-cardiac arrest was the added dead space on the patient's circuit. I mean, it wouldn't matter decades ago when we ventilated with tidal volumes above 600, but now, as the trend at that time was starting to target lower and lower tidal volumes, the added dead space could have an impact on the alveolar ventilation, which is a major disadvantage to its widespread use in that center. On the other side of things, in the cardiac center, we followed the same suit as the trauma center. Bought a few mainstream CO2 monitors, a few mobile units, and was never enough to cover all the hospital beds, and we sporadically placed them on patients. In 2015, when we were in preparation for the Glen Hospital move to the Super Hospital, the entire hospital again changed monitors, which had the optional module of a side stream or a microstream. And at that point, an emergency critical care physician who was big into the ACLS guidelines dictated he absolutely wanted end-tidal CO2 monitoring on every patient to guide management of cardiac arrest. At that point, because it was so fast and so simple with no setup time as the microstream is, we just put it on every patient and became quote-unquote standardized. The trauma center followed suit, and it's fast, simple, effective. They just put it on every single patient. And I think this presents an opportunity for RTs to contribute to add-ons when renovations are being done or new monitors are being purchased. So our physician champion was the one who dictated the need for end-tidal CO2 for potential cardiac arrest patients, but it was the RTs that followed through actually placing them and then even extending this to out-of-unit cardiac arrests with our MOBA end-tidal CO2 monitors. For example, we just took the RT, whoever was covering codes, take that portable end-tidal CO2, put it on the patient. the more exposure the other healthcare professionals have, such as nursing and residents, to the end tidal and guiding their management with that, the more justification it holds when management is debating to either purchase more or cut out the expense. Go to the next slide because it's not working on my side. Thank you. So finally, just to wrap everything up with ACLS, regarding the usage of end-tidal CO2 and ACLS guidelines, the American Heart Association used the adage, if you don't measure it, you can't improve it. So an ACLS is really two types of measuring and monitoring, and one is physiological, how the patient's doing, and the other one is the CPR performance, how the rescuers are doing. I'll just go to the next slide, please. So in regarding to physiological, end-tidal CO2 during CPR is primarily dependent on pulmonary blood flow, and then therefore reflective of cardiac output. So when we see an abrupt sustained increase to a normal value, this is a strong indicator of a return to spontaneous circulation. Conversely, the failure to achieve an end tidal greater than 10 millimeters of mercury, despite optimized resuscitation efforts, is a very valuable component when deciding if to terminate resuscitation. On the other side of things, on the CPR performance, monitoring end tidal CO2 during CPR assesses the chest compression performance quality. So now observers can integrate physiological factors such as end tidal CO2 with quantitative feedback of CPR, such as the depth, the rate, if the rescuers are leaning, to best achieve optimal CPR delivery. And finally, this talk would not be complete without discussing the airway, and capnography and airway management has been a long-standing gold standard. Historically, our centers use the very popular qualitative calometric CO2 detectors, and for those that don't know how they work, it's just a pH-sensitive indicator that turns yellow when exposed to CO2, purple poor, yellow yes. But there's a lot of limitations on using this device, such as if the device is clogged with secretions or broken, it's not going to change readings, it's not going to change color. It's a one-time 4 to 6 breath maximum indicator, and it does not provide continuous airway monitoring. And we know that when there's a cardiac arrest on the floors, you're transferring the patient from bed to bed, going to CT, going here, there, everywhere. There's a very high risk of losing your ET tube. There's also a lot of false positives and a lot of false negatives with using the calometric end-tidal CO2. So a false positive, you intubate the stomach and you get a change in color. This could often happen if a patient decided to consume carbonated beverages before intubating, or more commonly, very vigorous bag mass ventilation with a pressure of over 20 centimeters of water insufflates the stomach, and it does change the calometric monitor. On top of that, if it's exposed to any acidic fluids such as the stomach contents or lidocaine or epinephrine solution from the ampules, it could also change to yellow. In regards to false negatives, you get it in the trachea and it's not changing. This often happens in a low-flow, hypodynamic state of cardiac arrest, which could also arise if the patient has a massive pulmonary embolism or status pneumaticus. So with all these limitations, it's no wonder why quantitative waveform capnography has such a widespread usability. It monitors the breath-by-breath patency of the airway, the quality of resuscitation, and it indicates changes in resuscitation management. So since these implementations in our center, I've anecdotally noticed better management of cardiac arrest, whereas other healthcare professionals began modifying their practice around the end-tidal CO2 results, such as the nurses, first-year residents, and even med students by saying, hey, maybe we should check a pulse because he has an end tidal of 40. And that was the moment that I realized that this is the first step in actually changing the culture within our hospital centers. Now when residents come into our centers, they expect to see that end-tidal CO2 monitoring at every single code in order to help guide their resuscitation management. And that's all I have to present. I'm open to any questions if there are some.
Great, thank you, Marco. And for the attendees who are out there, if you'd like to send us questions using the attendee chat window on the left, we'll get to them either a few minutes after you send them or before the end of the presentation. So I'll turn things over now to Andrea from Vancouver.
Great, thanks, Carolyn. Hi, thanks, Marco and Cheryl, for that. That's great. So my name's Andrea, and I'm from Vancouver General Hospital, the professional practice lead. And going through my slides here, I'm going to talk a little bit about how we're using end tidal monitoring currently. I'll then go on to a little initiative that we're trying to get up and running in our spinal cord injury step-down unit. And I'll talk a little bit about the barriers that we're seeing to get end tidal monitoring used consistently. So in terms of end tidal monitoring, so we're using it as an objective measure to determine fatigue and respiratory muscle failure in patients struggling to wean from the ventilator. So we also use saturations and rest rate, but we're using end tidal during our spontaneous breathing trials for patients with spinal cord injuries, neuromuscular disorders, and respiratory muscle atrophy. So those patients that are really struggling to wean from the ventilator for one reason or another. And actually, we're doing a lot more lung transplant surgeries, and we're seeing some difficulties with weaning these post-op lung transplant patients from the ventilator. So what do we do? And I think in terms of, Marco talked a bit about a physician champion for this and in terms of end tidal. And so our 34-bed ICU is all the monitors are equipped with end tidal. We had an upgrade of monitors, and so we have the availability of the monitoring as well as on our long-term ventilators. We've put portable end tidal monitors onto all our ventilator stands. So we have the means to do it, and now it's just kind of going for who needs it, who can benefit from, and then some of the patients that we see some barriers with. So in this sense, we see our end tidal beginning to trend upwards as the patients become fatigued during their weaning trials, and this was outlined quite great in Carolyn's previous slide, showing the increase in CO2 while the rest rate and minute ventilation and saturations were fairly unchanged, and especially all our patients are already on oxygen, so even more reason to watch that end tidal as our oxygen is going to mask any sort of desaturation. So we use it to ensure adequate rest between the weaning trials. So it gives us data to guide our weaning trial length, and we really try not to fixate so much on the absolute number, but rather than the trend that we're seeing. So, and I think that's just one part of using your monitoring appropriately, and it doesn't necessarily need to be a cutoff value in terms of an absolute, but kind of how they got there. And like Marco was saying, we actually also use it to reduce the number of blood gases during weaning trials. So, some of these patients are doing multiple trials a day. That's, potentially multiple gases pulling off. But once we correlate the end tidal with the PaCO2, we're just going off the end tidal and not using the blood gases. So knowing that we have end tidal monitoring kind of going strong in ICU on these types of patients, we have an initiative ongoing on the spinal cord injury step-down unit. So we have 7 beds on our spinal cord injury ward and in a step-down unit, and they also had a recent upgrade in their bedside monitoring. We've standardized many monitors across the hospital, which makes it easier. And so we had, they included end tidal monitoring into the monitors. And so physician champions were useful. The same physician group from ICU covers the patients in the spine step-down patient. So it was the same physician group up there, and so it just kind of went hand in hand that they see the benefit of end tidal in critical care patients. So we've implemented this, but it's definitely still a work in progress, and I'll go through some of the barriers in the next slide. But the first thing we did is we came up with some patient criteria to help determine when continuous end tidal monitoring should be used. So, we use it in ICU on our ventilated patients, and on spine, the patient population is a little bit different, but we do have long-term ventilators up there, the PB560s and the Astrals now, so we can do ventilation on this step-down ward. And so we said all ventilated patients with the cuff up should have end tidal monitoring, and this is also built into our policies and our guidelines. If a patient has less than 2 hours of independent breathing time, we suggest having multiple alarms, and end tidal is one of those alarms. So that helped in terms of uptake of using the end tidal. So that was one of the patient population which we're already using end tidal on, but a couple other patients we've identified are those with high cervical spine injuries with neurological deficits. So these are the patients that actually do quite well. They didn't need a tracheostomy in ICU. They were able to be weaned and extubated, and now they're up on the spine floor doing rehab, but we're still, sometimes worried about these types of patients in terms of their respiratory muscle weakness that they may have, or their inability to manage secretions. And so we've set criteria to, if possible, use end tidal monitoring on these types of patients to catch any sort of early respiratory compromise. A couple other of the patients are opioid-tolerant patients, so those coming from OR and needing a lot of opioids to manage their pain, and using end tidal monitoring on these types of patients to again capture that early, like Carolyn was talking about, that early capture of respiratory compromise and failure. And then our OSA and sleep disordered patients. So we know that these patients are at higher risk, and using end tidal even while they're awake to help as again an early warning for deterioration of these types of patients. So that was this is something that we wanted to implement, and we're in the process of. But in doing so, we've come across some clinical barriers, and so I'll just go through those. I think that for the most part, the culture and the understanding of the respiratory therapists and the physicians, and slowly the nurses coming along now, people see the value in end tidal monitoring and the use of it, and now it's some of these clinical barriers that are preventing consistent use. So a lot of times our spinal cord injury patients, we've gone through weaning and we've successfully weaned them from the ventilator, but they still remain with a tracheostomy for secretion clearance. And the trach can be cuffed down or cuffless, and so they're doing well in terms of ventilation, but for secretion clearance they still need a little bit of help. And it's challenging to measure end tidal from a cuff down and cuffless trach. So like we know as respiratory therapists, the air is now coming out from their mouth and nose and out of the trach, and so to accurately measure end tidal, we can potentially look at it as a trend, but again, it can be kind of it can be variable. It could be positional, on how the trach is sitting, and if there's a little bit more leak, less leak. And so one of the barriers for sure, and this is big because many of our tracheostomy patients actually do keep the trach in until they go to our spinal rehab center. So definitely a big barrier in terms of being able to monitor. The other barrier that we're seeing is OptiFlow. So we've had a huge push from in the last couple of years, and we've seen great benefit in heated humidity. So going away from the aerosol nebulizer high flow to a heated humidity oxygen therapy system. And so with this, many of the patients are either using a nasal interface with the OptiFlow, and so again, difficult to monitor end tidal nasally with the OptiFlow already in, and we can use it actually if the OptiFlow is on a cuff-up tracheostomy patient, and we do that when we're doing weaning trials with OptiFlow. And so, but again, just another barrier to being able to actually use consistently end tidal monitoring. And then our last clinical kind of barrier that we're seeing is our patients on nocturnal CPAP and BiPAP. So, with a nasal mask or a full face mask, not being able to accurately measure the end tidal and see just because of the interfaces. So those are some of the clinical barriers that we're still kind of trying to go through. So when I talked about our other patient criteria, although many of the patients would fit the criteria to needing or could benefit from end tidal monitoring, some of these barriers actually limit them. So it's still a work in progress, but yeah, so. I think having the monitoring available and the buy-in from the respiratory therapists and the physicians is the key to get going. And so once you have that, I think you can kind of sort out these other things that may pop up. So thanks.
Great, thank you. And we just had one quick question for you. For the patients that have continuous end tidal II monitoring, how often do you find that the sampling lines have to be changed due to moisture?
Oh, that's a good question. So we were seeing it actually quite frequently in our ICU when we initially went live with this, and we switched to a different type of tubing that has the Nafion in it. I guess it kind of wicks away the moisture a little bit better. And so since we've gone to those other lines, we're seeing less of it. But I will admit it definitely can be a challenge for. It is a challenge that we're still kind of trying to overcome with having to change out the lines. And the other thing is just, keeping your eye on the water trap and making sure it's not too full. I think that the RTs are fairly good at that in terms of monitoring when we monitor our patients. But sometimes, education to the nursing staff to keep their eye out for that. So, it definitely was an issue, less of an issue now since we've gone with this other type of end tidal sampling line. So,
Great, thank you. All right, so we'll just take a minute and talk a little bit about, how you can implement change within your own organization. If you're not using monitoring, and we've convinced you today that you should be, how do you navigate that process to get it implemented? This is sort of a change management process that we've adapted from Cotter International, which is a consulting group, and their information's there on the slide for you. But really, there are a number of different steps that you need to do, and the first is to really communicate why your proposed change is so important, and that speaks to creating that sense of urgency. So perhaps you want to use examples from your own site of incidents or near misses that have happened. You can use stats relating to respiratory compromise from the literature, from your areas of practice. For example, Michael Mestek had some really compelling case studies when he presented in October to illustrate the need for the recognition of respiratory compromise. There are a number of guidelines from the Respiratory Compromise Institute and from the CSRT toolkit that are available that can all help you create that argument for why you need that change. Tom, I'm no longer able to see my slides if you want to see if there's any suggestion you have for that. They're back. Wonderful. Go back a slide here. There. The second thing you can do is build a guiding coalition. So this is really speaking to getting a group of people together who can help you navigate that change process. They don't necessarily need to be the ones that take the arguments through the chain and provide all the education, but people that can guide you through who do you need to speak to and what types of arguments you can use. You don't necessarily have to use people from your own department or even from your own hospital. You can reach out to people who have had experience implementing change to get some advice from them as well. For example, we have some panelists here who were able to rely on the help from some of their physicians at their sites to help navigate those changes. The third thing you need to do is really develop a strategic vision. As you're arguing for change or presenting your rationale for change, you want to say, here's what the end point is going to be. That's what your vision is. We want to reduce ICU readmissions due to respiratory compromise, could be an example. Really get that vision out there and use that as part of your argument, and then use cases from the literature, use evidence to support the links that you're trying to make. So, for example, in a situation where respiratory monitoring was implemented, here's what happened to their ICU readmission rates. We expect we would see similar results. To form that vision, but also clarify how the steps you're proposing, how the change you're proposing will get you to that point. And then you need to get your volunteer army together. These are the people who are really going to be the ones out there pushing and creating change. It's a huge process with a number of barriers as you go along. So having a group of people working toward the same goal will help divide some of that work up, but it also extends the reach of your connections. I love the example that Marco had, where he was talking about creating a culture where residents are now expecting this. Now, those residents will help drive change in their own institutions. People in your coalition, too, may have connections to industry that can help get you some support, help gather evidence. Cheryl mentioned a number of different professions that were involved in implementing the remote monitoring in her site, that helped get buy-in from physio, from the physicians, for example. So the more people you have behind your cause, the more you can divide and conquer, but also the greater the reach you have as you're trying to implement that change. And I think our three guests today did a great job of presenting some of the barriers that they faced, as well as the barriers that they're facing. And I think all three of them really illustrated very clearly that having a physician champion helped overcome some of those barriers. You know, we've matured significantly as a profession, but the reality is having that physician champion still helps us be heard. It still helps us drive our argument and drive change. Some of the other barriers that were mentioned by our presenters today related to the education. Cheryl spoke to an education piece that was so vital, where they had to, the companies came in, the RTs, they did a lot of education of nursing on the floor. Andre referred to education of nursing when they started to encounter barriers with their water traps. Marco spoke to the education that he uses when he's presenting capnography monitoring as part of ACLS, so people can start to make those linkages. Money is a barrier. And I love the fact that some of our presenters today were able to take advantage of upgrades to their hospital or to their monitoring system so that it reduced the expenditures for buying all new equipment. So the greater the group of people you have working on this change, the greater you can start to address and identify possible solutions to these barriers. And it's going to be sometimes a longer process, but you really have to celebrate the short-term wins when you have them. This helps you keep the forward momentum up, because change can take a long time and it can be a little bit demotivating. But if you have found a new article that supports your proposal, share that with your team of volunteers. You know, keep that morale up and keep that momentum moving forward. And that helps you sustain some acceleration as well. And then as you institute the change, you really want to continually articulate the connections you're making between that new behavior, whatever change you've made, and the success, you know, the success to the patient, the benefit to the organization. Those types of things will help cement the change and make sure that it's sustained over the long term. So we've presented a lot of information to you guys today, and I know it's been a short time period, about 50 minutes to go over all this stuff. Most of this information has linkages to it through the CSRT Respiratory Compromise Toolkit that's available under our Resources tab. This is just a screen capture from that. There's a section for risk factors, a section for guidelines. Some of the testimonials that we have on our site led to us inviting our presenters today, and then some information on change management as well. All right, I'm just going to see if we've had any more questions come in. This would be a great time now for any questions, comments, criticisms, queries, or concerns. All right, while we're waiting for some questions to come in, I think I'm going to ask our panelists again. Do you have any advice for anyone who wants to implement either remote or continuous monitoring in their sites?
Hi, Caroline and Cheryl. I think the biggest thing is to actually have a great team. And I think that's have somebody who owns it, a great leader, you know, a couple of champions, and a great group of people that will work together towards change, because change for anyone obviously is a challenge, and there's often resistance to change, but I think that can be overcome with a great team.
Great, thank you. Marco or Andre, do you have any advice for anyone who is going through a change process or hoping to implement some change at their sites?
Well, I understand the importance of a physician champion even through ours, but one of the highlights that I said in my talk was that even though the physician championed it to obtain it, it was really the RTs that, you know, took one of the mobile unit for every single code and just didn't wait for anybody to tell them. They just put it on, and then they gave their suggestion to the residents who were running the code saying, hey, maybe we'll stop because, you know, we have Title 40. So I think there's a strong importance of taking the initiative even as a department by saying, okay, we have this tool now. Don't quote unquote forget it when a code rings. Bring it, use it, and the more people that get exposed to it, the more justification it holds, the more importance it holds in its daily usage.
Yeah, I think you speak to 2 points there. One is really being the champion of yourself and making sure that change is sustained, but also there's a great role for respiratory therapists when it comes to implementing these monitoring tools on the floors. We are the oxygenation and ventilation specialists, and when it comes to monitoring exhaled CO2, that is fairly new for a lot of the professionals on the floor. So I think you speak to the role RTs have, not only in sustaining the change, but educating people and overcoming that barrier too, Marco.
Mm-hmm.
Yeah, and it's Andrea. I think too, just with anything in terms of change, there's going to be things that don't go right initially, and it's just about trying to find solutions. So, if we've talked about a nuisance alarm because the sample line keeps filling up, then seek out alternatives. And I think that's where respiratory therapists need to come in. So, it's one thing to just silence the alarm and walk away, but what was the cause of the issue and how can we solve it? And I think that, by us taking that step and sorting that out, kind of shows that we believe in the monitoring and in its value, and that we're willing to kind of, figure out those issues as they arrive.
Yeah, and I think too, what we'll find is, as we make connections across the country with each other, if you're having a problem at your site, chances are someone else is either having the same problem or has had it and found a solution. So using tools like we've got a listserv that you can post your questions on, and inevitably you get some answers, or reaching out to other sites that have implemented the same technology using the supplier or the equipment company, who may be able to help you make those connections also. All right, are there any other questions? I don't think any others have come up. I'm just going to scroll back through. Wonderful. So thank you very much, everybody. I do appreciate everyone who presented today and helped pull this first panel discussion together that we've ever done through a webinar. And of course, Tom, for all of his tech support as we went through this. I also have to thank the folks at Medtronic that helped me prepare for this today as well. This presentation will be available probably by the end of the weekend on the CSRT website, and you will be getting an email following today's presentation about how to get your participation certificate. So unless there is anything else, I'd like to thank everyone, and we will sign off.